Please welcome to the stage John Blum, Mandy Cohen, and Mickey Tripathi.
Careful of that.
Attacked by the flag. Oh, do we have? Oh, yes. Okay, great. Thank you, everyone. Thank you, everyone, for coming back. We're going to start our next session here. I'm really delighted to have a discussion with my colleagues, Dr. Mandy Cohen and Mr. John Blum. John is the Deputy Administrator of CMS. Mandy is the CDC Director. And we just couldn't be happier with, with the partnership that we have with both of them at a personal level and with their agencies and their teams. And I also want to give a special thanks to both of you for being here in person. I know both of you have the craziest schedules probably of almost anyone I know. So I know it's not easy to show up in person, especially when you're based in Atlanta. So I really appreciate your coming here. So we're just going to go through a set of questions related to interoperability, your agency priorities, how you see TEFCA, helping with, to support you, because I think as both of you know, what we've been doing at ONC is doing everything we can with TEFCA and everything else to best support you. And you're the mission, and so we want to be able to do everything we can from ONC to support the missions that you have in public health and in healthcare delivery. So first, wanted to just have a little bit of discussion about interoperability in general. Both of your organizations are leaning pretty heavily into interoperability. CDC with the Data Modernization Initiative, CMS the Draft Interoperability Rule, healthcare directory work, everything you do with payment policy. Where are we on those initiatives? So maybe I can start with John. Okay, great.
Thanks, Mickey, and thanks to the whole team that you have. Just a phenomenal partnership. Thanks to our CDC colleagues and Mandy Cohen as well. We're really excited just to see everyone here, and it's great to be here in person. For CMS, that we see one of the key challenges for us going forward is how do we get more healthcare output with a very shrinking workforce, with a very constrained overall healthcare system. And so we see part of the core mission for CMS is to do anything that we can to take away burden, to give back time back to the healthcare system that is taxed right now. And if we think about what is the key challenge for our beneficiaries, it's not necessarily taking healthcare costs out of the system, but the key urgency is for us to bring healthcare costs back into the system. Primary care, behavioral health, key challenges for us right now. So if we can find ways to use CMS leverage, to use CMS tools to really create more common standards, more shared services. So why should every hospital have to navigate 15, 16 different prior auth programs and processes throughout the system? Can we create one common system, one common standard to really, give the freedom to the health plans to define clinical policy? But if we can't make it easy, we can't make it simple for the very busy clinician to really navigate those processes, then really shame on CMS. And so what CMS wants to do going forward, with prior auth being one of those first pieces, is to find ways to create common tools, common standards, common shared services. So first step for us in the next several months will be to finalize regulations to create common standards for how we provide information to clinicians regarding prior auth. But you will see CMS think about next steps. We are very interested to create common directories, to have one standard for how providers submit data to payers for their locations, their address. Couldn't CMS in the future be that one source of truth to really take time, burden, give it back to very busy clinicians?
Great. Thank you, John. Can we close the door in the back, please? There's a lot of noise coming.
Yeah.
Mandy.
Great. Well, first, also want to thank you, Mickey. I think you've just done a terrific job of moving some really, really hard rocks forward. So congratulations to you and the team. Yeah. I just want to share, being newer in the CDC role, and so happy to be back at the federal level, and I miss being at CMS where I was for 7 years. I think the level of partnership that I see across ONC, CMS, and CDC is really unprecedented. And I think we've learned a lot during the pandemic. And let's be honest, like public health has been completely siloed from how we've been thinking about some of the data efforts. But the pandemic shook us in a way to say we really have to make sure that we are integrating public health into the health delivery IT ecosystem. And I think the work that is being done right now is really, really an important step forward to laying that foundation. But I think there's been a lot of really great work, and I want to really congratulate Mickey. I know you've been a part of this and been a champion helping CDC well before I got there, that there's been a lot of progress made. And I'll just say, as someone from in North Carolina, when we were leading in the pandemic, we were still doing things with fax machines when the pandemic started. But there was a huge investment that was made to automate a lot of the processes that are necessary to identify and respond to health threats. So we're in a much better place than we were. So I'm really pleased to see that right now we get ADT feeds from 80% of the emergency rooms across the country, right? So that is a hugely important national security asset for us to have that sort of level of visibility to the emergency rooms, right? When people are sick, you don't know what they have, they're showing up in the emergency room. So that link between public health and healthcare is so critical. And so to have that level of real-time visibility for CDC right now is critical. So for example, even just a few weeks ago when we were hearing some reports about mycoplasma, for example, in China, we were able to immediately look at our network and say, well, what are we seeing here? Are we seeing anything unusual? And we can report right back to say, nothing atypical is going on, right? So an immediate way of being able to reassure the public about what's happening. So 80% of our EDs, but what we're really focusing a lot is on electronic case records. So in public health, it's really important for us to get standardized information about what's happening to an individual patient so we can try to make linkages to what's happening around. And we have learned through the pandemic how important it is to know what's not just happening in New York, but what's happening across state lines, right? No disease is respecting state lines, so the interoperability here is so critical. And so I think the investment that CDC has made in electronic case reporting is really working, but we're only at about a third of hospitals doing that as right now. We see about 10% of our ambulatory providers using that. So work to do to get more folks using that process, but we have to be at a place where we're comparing apples to apples with similar standards, with less burden, so we can save folks time and we can reduce burden on folks so they can focus on taking care of patients, and then we in the background can be looking at that data to understand what it might be telling us so that we can do response efforts.
Right. Excuse me. And I will note that for those who haven't had a chance to read through the 950 pages of the rule that we dropped yesterday, I know it's taking you so long, that one critically important piece of that, of HTI 1 that we worked very closely with the CDC on is upgrading essentially the EHR certification requirements related to electronic case reporting. So to the extent that we've got that big gap, the requirement in certified electronic health records has been up until now a functional requirement, which is to say, here's what constitutes electronic case reporting, but there was total optionality in terms of how that was actually done. And there'd been, sort of industry consensus around, a certain set of things, but it wasn't getting the scale that we want to be able to get. Now, with the passage of the rule, there is now a technical requirement, both a CCD as well as a FHIR version of the technical requirement for electronic case reporting that we hope will, sort of greatly advance the ability to do it, because at the end of the day, it's about making it easier to report from the provider end that gets it done. Which leads us to the next question, which is, I mean, both of you are, sort of familiar with, you've heard me talk about TEFCA ad nauseum. But, I'm just wondering now, how do you see TEFCA supporting your work? Are there concrete initiatives that you're starting with that begin leveraging TEFCA? Any perspectives you have on that? John, maybe you can go first.
Sure. I want to start with a story that came to us during travel down to Florida. And we were meeting with 4 ACO organizations. And they were very experienced physician practices. They were taking risk. They were taking, very forward-leaning stands for how they participate within the Medicare program. And all 4 of them said, when asked what their greatest challenge is that they still cannot get connection to hospitals that when their patients that they're caring for are in the hospital and are being discharged. And one of the arguments to us when thinking about the ACO program, say 10, 15 years ago, that the greatest opportunity that we have for care coordination, for care navigation is to really have that warm handoff from the hospital back to the physician practice. So think of someone going through surgery, think of someone going through cancer care, think of someone that was hit by a car that needs really, really intensive care. And today, 4 advanced primary care organizations told us that they still cannot get the data feeds, the connection, the warm handoff from the hospital back to them when it's time to have that care discharged. So if we believe in value-based care, and if we believe that there is promise in care coordination, and we are probably 15, 16 years since the start of that really hardcore journey, this is the reality that we have today, that the hospital systems, the physician practices, the pieces that really form the healthcare journey still do not talk to each other. And so we have to do better to really reinforce that. And so whatever standards, processes, connections that are going to really reinforce that vision of the healthcare system not being in silos, not protecting information, not sharing information, but really seeing that each piece connects to that total journey, that's where we need to get to really rapidly. And so one of the greatest surprises to me personally coming back into government is the political support for value-based care is really diminished. And I'm sure everyone here in this room believes in it, and CMS believes in it. But we've got to create stronger arguments for what is the purpose, what is the reason that we're spending so much energy trying to think about better payment models, better healthcare vision. But if we cannot have that simple step of the patient coming out of the hospital, coming back to community, and the hospital is not sharing that information back to the primary care practice that has the best opportunity to prevent the readmission, then that's a tremendous failure. And so we've got to do better. And if TEFCA can help us get there, then game on, and you will see CMS use the levers that are now to our disposal to really reinforce that purpose, that connection that we desperately need to come back into the healthcare system.
I think it's such a great point. Before we turn to Mandy, just for a second, that with TEFCA, I think there's the governance and there's the technical standards, and there's sort of the plumbing, both from a policy and legal perspective as well as the technical perspective. But I think, and one of the QHINs had said this at the Tuesday event, that from what they see with their customers is the value of TEFCA and the public-private sort of partnership in TEFCA is the clarity that it hopefully brings to the market. Because I think one of certainly my experience in as a patient or as a steward of a patient, my mother in this case, had the experience of her having a medical event, a broken hip, bringing her from the hospital to the rehab center, which was less than a mile away. Both of them on very sophisticated EHR systems, let's just say, but different systems. Mm-hmm. And they're handing me a stack of papers. Yeah. And as I said to them, you're doing this right in front of me, with no shame. and one of the fascinating things about that was that they are connected. They are absolutely connected. I know they are for a fact, but the frontline people did not know that. They had no idea, and that's not their fault. but they had no idea. And I think a part of that is, yes, we all need to implement at the last mile, the last inch, the last angstrom. But it's also because there's confusion still about, well, there's the state HIE, there's, this and that, and faxing is still easier. And so I think, hopefully what we can do with TEFCA is it brings a little bit of more of a sort of clarity across the market, that everyone should just be asking, all right, how am I connected to TEFCA? Whether it's a physician office, whether it's a hospital, they don't need to know how they get there, but just being able to say, yes, I'm connected to TEFCA, that gives me assurance. And for a public health agency as well, as they think about their interoperability needs, we want that to be their first instinct. The first instinct isn't the fax. The first instinct is TEFCA doing this for me?
Well, I think TEFCA is a game changer. And again, Mickey, ton of credit to you for really driving this forward. Like I said, I think it is so important that we are plugging public health into the healthcare IT ecosystem. And I think TEFCA is exactly the right platform that helps accelerate that work. So we at CDC, we're leaning in. And so look, public health has been left behind in terms of the modernization efforts. And so I think TEFCA hopefully can help us catch up and make sure that we are leaning in. So we have already, thank you to you, and I want to congratulate Dr. Jen Layden at CDC is a really tremendous leader, and I'm so pleased of all the work that she is doing. And if you don't know her, you should get to know her because she is already leaning in with the whole team on planning how we are going to take advantage of TEFCA. We're already recruiting our first public health jurisdictions to say who wants to raise their hand and be part of this. And we're putting money on the street. So there is $90 million actually that we recently announced to say we want implementation centers to help public health jurisdictions to be TEFCA enabled. And so we have some big goals that we're setting for ourselves to make sure that we're taking advantage of this opportunity because we know public health has been left behind before. So we're gonna get on the train here. And I think it's a big deal, right? Because in public health, we're doing a ton of point-to-point connections, a ton of, for each disease state, we have a data use agreement. That cannot be the way forward. So we want to make sure that we have the opportunity to move past this point to point and everyone sharing one directional, but have this common platform. I think is going to be really, really critical. And again, what I'm hoping for public health is it not to feel siloed, not to feel extra burden. Oh, this one more thing I have to do, but we all be integrated into this one joint system. Again, thinking about someone's journey, imagine that journey included an infectious disease component of what they were doing, or in making sure that we're identifying things quickly. Time is money in an emergency, so TEFCA is going to be a big game changer.
Right. Can I poll just? Let me just ask to pull a couple of threads that you had there. One is just to highlight, in case that sort of flew over everyone's head, the CDC's putting money on the table to get implementation centers up and running to support TEFCA adoption for public health agencies. $90 million, the RFP is now on the street.
That's not as big money as CMS, but that's a lot of money for CDC, so take a look.
And hopefully it's a start, right?
Yeah,
I think the idea is to say, who are the early ones who it's harder for them to figure out, well, what's the value proposition here? I've got my existing infrastructure. There's investment that I would need to make here in my state. And how do I get over the hump, even though I may have every desire to connect up to TEFCA? I think helping to bridge that gap with an eye toward also, as the teams have been working very closely together on how we design that, taking a lot of lessons learned from the ONC Regional Extension Center program that many of you may remember, to say how do we get those lessons learned so that it's not just money, it's about providing the in-kind support to be able to help people, because let's face it, public health agencies don't have people sitting around just waiting for the next implementation thing. They're already hard at work. They've already got their queues of the backlog. So being able to provide that support as well, I think, is hugely important. The other thing is just as you had I think noted, some agencies who are really interested in doing a little bit more. We've been thinking a lot about electronic case reporting and some of those capabilities. I don't know if there's anything more more you can say about that, but we're hoping to get some concrete activity there.
Yeah, I will say I've been traveling around the country. I have gotten a lot of frequent flyer miles in the last 3 months, and meeting with a lot of folks, and there's a lot of excitement about TEFCA, what that can offer. Folks are raising their hand right away. So we're going to have a number of jurisdictions who are going to jump on this, but it's one step at a time, and then we have to work through this, which is why we know public health is going to need help, which is exactly the reason we're putting dollars behind it.
Yep, great, thank you. So let's think a little bit about the future. What do you think this looks like 5 years from now? Just to pick a number. As both of you are thinking about, your worlds, what are you hoping that this can accomplish? And I know both of you are also very grounded in reality, so I know that, it's not going to be, we're going to have flying cars, 5 years from now. But just in thinking about, the sort of things that you've already got in play, that are the policy priorities and the programs, would love to get your sense of, just from a realistic perspective, what would be some, some stretch but realistic things that we can say, yeah, if we all do our jobs, which we're going to keep doing, what does that look like 5 years from now?
Kind of 3 points come to mind, and I'm sure there's many, many others. But the first is the simple reality, and I think the simple kind of statement for CMS is that we're covering roughly half the population today through some CMS program, Medicare, Medicaid, private marketplace. And that is a phenomenal place to be. And just about everyone here in this room during some time during their lifetime will navigate CMS programs probably several times. So you'll change a job, you'll have a baby, turn 65, and you'll come into CMS world. And so I think the challenge for CMS is for us to think less about the silos to our programs and more about the continuous journey. And so with Medicaid redeterminations happening now throughout the country, the greatest opportunity that we have now is to help people seamlessly change coverage with minimal friction. So I think one vision statement for us forward is that as people navigate life choices, that their insurance will follow very seamlessly forward so it doesn't disrupt their network, doesn't disrupt their care plan, doesn't disrupt their overall healthcare journey. We are certainly not there today, but that's the future statement that I think we can aspire to, and better data, better information, better transaction will certainly facilitate that. And so that's kind of the first point that comes to mind. Second point that comes to mind for a 5-year vision statement would be back to that notion of that primary care practice. And does that primary care physician practice, do they have the information they need to ensure their populations, their patients are staying healthy, are navigating very sophisticated care journeys? That is not the healthcare system that we have today. And so we're going to have to do a lot of work to really redefine what we mean by delivery system transformation, particularly after the past 3 years. But that vision of complete information, seamless data flows, the patients have minimal friction navigating very complex healthcare systems, that to me is another 5-year vision. And I think more for CMS itself, that despite the great data resources that we have, and I think that we can get from CDC, we don't have that to our fingertips to really make good decisions. And I think the pandemic really illustrated that for CMS, that we did not have the information that we needed to make fast, real-time decisions for how to help support the healthcare system stay open. So if we could get to a 5-year vision statement that would say that we collectively in our country, through our public health programs and health insurance financing programs, have every piece of data that we need to make the best possible decision, that should be part of that 5-year vision.
Great. Can I just want to draw you out on a couple things. One is the interoperability, the draft interoperability rule. And I know that's in rulemaking, so obviously limits on what you can say there. But how do you see TEFCA helping to support? I mean, you've got this. I think I'd love to boast on behalf of CMS about the great stuff that you've been doing with FHIR APIs. You've got the internal APIs, the BCDA and the DPC, but then you've also got the member-facing API requirement from the 2020 patient access rule, and now you've got the draft rule for prior auth, for provider access, for payer-to-payer. we see TEFCA as hopefully sort of energizing those and accelerating adoption of those, but we'd love to get your thoughts on that.
See it the same way. So that we see TEFCA really as the turbo boost behind many of the initiatives that we're putting into place. And so if TEFCA can help us get there faster, get to that 5-year journey faster, that is a huge opportunity, not just for CMS, but for our whole country. Healthcare will be better. Healthcare will be lower cost for the consumer. A tremendous urgency, just to say it again, is we have to figure out how we take cost, waste, burden out of the healthcare system. And so anything that we can do to accelerate that pathway, that is the urgent call for CMS. And so, again, you will see CMS use the levers behind that we have to really accelerate this transformation. Just don't have time to wait 10, 15, 20 years for us to hope that those connection points begin to connect. The urgency is too great, the need is too great. The healthcare system is stressed beyond anything we've ever seen before, and so that is the urgent call for the agency. Right,
great. Well, I know for those of you who heard me this morning, you talked about my promise to be impatient, and that's one of the things I love about my colleagues, is that all of us as agency heads are very impatient because we want to get some big things done. Last thing I want to ask you, John, before turning to Mandy, is related to healthcare directories. I know you've got some early work there in thinking about that. We've been working, with the team of thinking about, TEFCA obviously launches with a nationwide electronic phone book, which is already starting to get populated. The hope is that that really complements what you're doing in the healthcare directory side. And I know I don't want you to get out ahead of where the process is, but would love if you can share anything about how you're thinking about the healthcare directory side.
Sure, of course. During my time between CMS tours that I spent working for a health plan here in this area, and we probably had 65 staff that mostly did provider credentialing, chased down the information of the address, the location, the times the physician practice were open, and we still couldn't get it right. And the information was poor quality, and it was great regulatory risk to the plan. It was great cost and burden. And so when you think about that kind of magnitude of every health plan, every hospital system, every physician practice, chasing that information, submitting the information that's not accurate, that changes quickly, that doesn't have one source of truth. And so again, for us, that is the purpose of CMS, is being at the intersection of these major insurance programs, but we should be thinking about us as the source of truth. And if we can think about a vision that would say that information needs to be submitted once, a health plan can grab it, a hospital system can grab it, that there's confidence that it's as accurate as the physician, the hospital will attest to, that would take so much cost and so much waste and so much energy that goes into every piece of the healthcare operation, and translate that to a more seamless care system, a less friction care system. That is just a huge opportunity. This is a long-term bet that CMS is placing, but that vision really of us taking so much time, energy, bad information out of the system and giving it back, that to us seems just like a tremendous opportunity.
Right, and I mean, it's a tremendous vision, and certainly ONC and TEFCA are here to support that.
Excellent.
And I think that the work that we do to say, well, we're already up and running with the endpoint directory, which I think, as we all know, is different than the kind of directory that says, well, what are the doctor locations and what are the physical addresses? But being able to say those are pieces of the puzzle that through federation you get, sort of the whole. I think that is sort of the key to the future here, and so it's a really exciting opportunity.
Okay, thank you.
5 years, Mandy.
Well, so before we look forward, I think we need to look back at what we saw during the pandemic and the vulnerability, frankly, that our country saw because of the lack of data infrastructure that we had. We all had some what we thought were pretty basic questions that we wanted answered about what was happening what do we do to protect ourselves? How do we move forward? And we didn't have it at the beginning. And I think we've made a lot of advancements, but I think in 5 years, we can be at a place where we are able to collect data in a way that is able to answer for the American people some very just common and basic things, like how many people have a thing, how many people are in the hospital, right? So we're not lighting the world on fire, but they are super basic and frankly necessary for the protection of our country, right? As I think about CDC as a national security asset, meaning an asset that can rapidly identify and respond to threats, just like our military would respond to a threat. The data infrastructure is the oxygen that powers that. And so, we have some pretty ambitious goals over the next 5 years to automate a lot of what that is. So a lot of it is using TEFCA to allow us to collect these electronic case records from at least 75% of healthcare entities. So I mentioned at the beginning, we're about 1/3 of hospitals, 10% of ambulatory sites. 75%, I think, is a big stretch goal, but I think it is absolutely doable, and frankly, we have to do it. We have to go in that direction, and I think if we do, we actually reduce burden on the healthcare system, on public health as we move forward. I was just looking at one example of when an outpatient ambulatory setting in our community health centers implemented electronic case records. It was through OCHIN. For those of you who know, it's the health centers that are associated with Oregon, but they're in a few states. They implemented electronic case records, and within 1 year, they generated about 1 million case records, right? That's the amount of work. So they have about 22,000 providers, 1 million case records, and they're estimating it saved them about $4 million in staff time, right? To all of that reporting to different jurisdictions with different, right? So that's
higher quality, lower cost.
I mean, that's what we're after here, and on the public health side, it's faster response time, right? And then it's better care for the patients and faster response times and safer communities, right? So we have to do it. It's an imperative that we need to get to. So we're going to keep plugging away at this electronic case reporting. If you haven't heard ECR, you're going to hear it a lot. So that's what we're going to be talking about. So we've done the surveillance part, as I mentioned, with the emergency rooms. That's good. We've had good coverage. We're at 80%, good. But now we got to get to the electronic case reporting over the next 5 years. We're doing what we can to invest. Like I said, I think TEFCA is the accelerant for that, because we want them to be TEFCA enabled, because again, that avoids that point-to-point interaction and it speeds things up. So that's our future. It's data completeness, right? If I think about all of the data we get some good data, but then pieces are missing, right? I don't know race and ethnicity, or I don't know age, right? And so we can't give the American people a full understanding of what's happening. So it's data completeness, it's the burden, and it's the time. So in 5 years, we're going to make some major progress on that, but I need all of your help to do that. And certainly, again, thank you for the partnership across government. I think it's been remarkable, but we got to press on.
Right. Thank you. And I think there are certain sort of components that we've been working on together to help to build that future. One is, as you talked about, data and data completeness. Again, I don't know if all of you heard, we dropped a rule yesterday. It's 958 pages. But US CDI version 3 has a number of the data elements that you're talking about. And hopefully that gets us to a place that you're able to have more complete data that start to extend out to social determinants of health, more robust reporting and availability of race, ethnicity, language, other types of data that drives a little bit more uniformity between the healthcare delivery system and the public health system, so they're really just different aspects of the same system, not different systems, which is kind of how they live today. So that's sort of a core construct. I think what we want to be able to do also with FHIR is being able to help with the opportunity for public health agencies to do a query of information just using FHIR-based exchange, where right now, everything, the way our systems work is static reporting. It's, we want to get to 75%, and even that is like, well, it's static reporting of a static report delivered one way, and, and still trying to figure out what are the workflows, how do we get technology to enable the kind of dynamic sorts of integration and interactivity that exists in the rest of the internet economy. And I think FHIR-based capabilities are kind of key to that. So certainly what we've been working on with Helios and others is the ability for public health agency to do the follow-up electronic case reporting. The stretch goal of, all right, now I got the report, I need 4 other pieces of information now to do that case management and track that down. I have to pick up the phone or I have to send a fax. No, that's a FHIR query, 4 data elements, and I get it back.
And we're seeing that work already. So even in California, they picked up a few cases of what's called silicosis, right? If you heard of asbestosis, silicosis is sort of similar. It's a lung disease. And again, it's where, how does public health go out and query to say, we know we're seeing a few of these cases, we know there are more out there, and we want to proactively reach out to patients, right? That's the query that can already be working. And in California, they were able to identify 70% more cases than if they were doing the pick up the phone manual way that we've always done it. So I think there's a lot of opportunity there, not just to be reactive, which is the national security piece, but to be proactive and to be making sure that we're using this to reach out to folks. So a lot of exciting opportunity, but we have to keep just one foot in front of the other and marching forward and keep explaining why. Why is this so important? Why do we need to keep investing in it? Because it does take time and resources, and everyone is stretched thin. So the investment now to get to that future is really critical.
Right. And it hopefully gets us to the same place that you were describing before with OCHIN, which is we get higher quality, better type of interoperability at lower cost once the dust is settled, right? There's always investment to get us to that place, but once the dust is settled, being able to demonstrate that it actually is lower quality, lower burden on both sides of the equation. So I can't thank you both enough for everything you're doing, for your partnership, which I highly treasure, and for being here today. So thank you.
Thank you very much.
Thank you, everyone.
Thank you.
Thanks so much, Jim.
Thanks, Vicki. Good job.
Oh, yeah.
Yeah, so that'd be good.
I'd like to get some
Anish.
time.
Yeah.
Okay.
Yeah, Anish is trying to get us
Thank
together.
you so much for coming.
Thank you.
All right. I think we're ready to get started. My name is Steve Posnack, serves as the Deputy National Coordinator for Health IT. I'm hiding behind this podium for those of you that are on the far right side. Sorry about that. We have continued to include our federal partners here, just like you had from CDC and CMS. So it's my pleasure to be joined by 2 of our colleagues from other component sister agencies at HHS, including the Indian Health Service and NIH, and then our colleague from VA as well. So we will dive right in because I only have 25 minutes and we have highly optimized panel presentation here for you today in discussion. Each of you have various initiatives underway to modernize your health IT infrastructure and leverage data systems for a variety of purposes. So I think just to give the audience a sense of where you're at and an introduction to yourselves as well, which we thought would be a little bit easier for everyone. I'll go first to our colleague from VA.
Thank you. Sharif Elnahal, Undersecretary for Health at the Department of Veterans Affairs. I'm responsible for our healthcare mission, our hospitals, clinics, nursing homes, and our healthcare delivery mission at the VA. And so I want to thank you and Mickey for inviting us here. In a meeting that Mickey had convened just this past February, we had talked about the vision for what interoperability can mean for veterans across the country, to include on missions like suicide prevention, but also awareness on the President's groundbreaking and signature achievement for veterans, which is the PACT Act, extending benefits and care to veterans exposed to toxic burn pits and Agent Orange in Vietnam. And so we're already realizing that vision with a partnership with 13 health systems who pledged to work with us for seamless information transfer between the VA and their institutions. About 1/3 of our care is sent to the community out of necessity in many cases because we don't have infrastructure in certain parts of the country, especially in rural areas. And Director So is my partner in serving tribal and Alaska Native veterans as well. And so we rely on community partners. And so we're already delivering on a use case for this as of January. We have a groundbreaking policy, for example, that allows us to pay for care and also directly provide that care to veterans who aren't enrolled in our system, but who come in with suicidal crisis. For the first time, we can serve almost all veterans, regardless of whether they're enrolled in our care. And because of that partnership, social workers at these 13 health systems will be able to get a printout of veterans who showed up to their emergency rooms not having known that they are veterans, but they are querying our veteran identifier API to determine that. So that's just one example of how this can be really used to, in fact, save lives. I also just want to mention that we're undergoing AI tech sprints now to get solutions in place like ambient dictation and outside hospital record synthesis for our providers to temper clinician burnout. The interoperability pledge will help us test the interface that we're setting up with these 13 health systems, and hopefully through TEFCA, the rest of the American healthcare system, to share that ROI.
Awesome, thank you. And organically, our panelists went up and down in their seats, just exactly how I have the questions. So let's go to NIH next.
Hi, thank you so much. I'm Susan Gregorick. I'm the Associate Director of Data Science for the National Institutes of Health. Interoperability is a key component of our NIH data strategy. With over 80 patient participatory data platforms that hold everything from genomics to de-identified electronic healthcare related data, interoperability is really key. That many platforms really requires interoperability, and so leveraging TEFCA and FHIR is really part of our strategy. And just as a note, we have been using FHIR, as Mickey said, to find data across at least 5 different platforms, allowing researchers to find, aggregate, and analyze data in the cloud. We also are bringing the community along in our applications of FHIR by offering FHIR trainings both to our internal NIH researchers who work with clinical data, as well as to researchers who are part of our clinical translational research resource centers in IDEA states. So we do have to bring the community along in work that is happening with USCDI and FHIR and TEFCA, and we're certainly willing to do that and really happy to start working with ONC and others on interoperability.
Awesome. IHS.
Good morning, everyone. Again, my name is Rosalind So. I'm the director of the Indian Health Service and a citizen of the Navajo Nation. I really appreciate the opportunity to be part of this conversation and including the Indian Health Service in this dialogue. At the Indian Health Service, for some of you that don't know, we work with over 570 tribes, federally recognized tribes across 37 states, and we have a health network that expands more than 600 healthcare facilities, hospitals, and where we provide a comprehensive level of care. There are lots of opportunities that creates for us and lots of challenges that creates for us. One example, about 2 weeks ago, I was out traveling in Indian country, and I traveled to the bottom of the Grand Canyon. And we just recently refurbished one of our healthcare facilities out there, and you can imagine that there's only a few ways that you can get down into the Grand Canyon. You either can hike down there. If you're lucky enough, like I did, I was able to take a helicopter down. But those are the challenges and those are the complexities that we deal with every single day in the work that we do in these very, very remote locations. So not only is data and what we're doing at the Indian Health Service to improve data is so critically important, but trying to make sure that infrastructure that allows us to do that is also built into the processes that we have. And with that, with all of the challenges that we all remember that COVID-19 brought to us, there were also many opportunities. I think it really is forcing us to look at our healthcare system to make sure that we're building a healthcare system for the future that's going to span across the country, not just Indian country for us. We also provide healthcare services to about 2.8 million American Indians and Alaska Natives, again, all through the United States through this healthcare network. There's also a provision that tribes have called the Indian Self-Determination Act that allows tribal entities to take their program that used to be federal. They now take those resources from the federal government, or in our case, from the Indian Health Service, and they can develop and they run their own programs for their own, they develop their own healthcare programs for their communities, for their tribal people. So that brings, again, another layer of opportunity, but also complexity in terms of when we're talking about the systems that we're trying to build out here. And then finally, going back to my colleagues here in the conversation about veterans, you know, I travel through Indian country, and one of the things that I hear that's just absolutely heartbreaking is when a veteran says, because they have a choice to either go to IHS or to the Veterans Administration. And these veterans are having to tell their story not only to the VA, but to the IHS, the records, there's no ability for the record to sort of seamless follow them so they can get the best care possible. So for me, you know, I'm the daughter of a Korean War veteran, and that's where it was absolutely clear to me that what we need to do and what we're trying to do at the Indian Health Service and across the government to build out our healthcare system is absolutely critical, because my father decided he wanted to have his care at the IHS, but he also had benefits at the VA. So I think as we move forward and really think about what it is that we're trying to do to build out a healthcare system, making sure that we build in the capacity to have our data, which is absolutely critical, and we also know that that was critical during the pandemic, and how we leaned on that data. We had to lean on that data to make sure that we are addressing the needs of our people. So I'm excited about this, and I think that we have a lot still yet to do, but IHS is ready and prepared to take the next steps.
Awesome. Well, we will stick with IHS quickly. You've already, I think, highlighted in some of your opening remarks the unique needs that you have in supporting tribes. You also are a health IT related investor and provider, and have clinical staff as well through IHS delivering care. Could you give us a sense of you know, how supporting the tribes is unique in using health IT to improve care, and some of the things you have coming forward in the future?
Yes, thank you. And again, leaning back just very recently with regards to the pandemic, I was at that time the director of the Navajo area, which is a huge, about 25,000 miles of land, and so we're trying to provide health care to the people that are in that particular area, and not having systems that are able to, you know, to be inoperable and be able to transfer data, that was very critical. But what we were able to do was stand up a program very, very quickly that allowed us to identify the hotspots in Navajo country to where we could deploy resources. At the IHS, we have a workforce of 15,000 federal employees, and then of course the rest of the tribal entity that goes into that. So again, while there are clearly complexities in the healthcare system that we provide, part of what we do well, I think, is really leaning into the relationships that we have with tribes, that even though there's more than 570 federally recognized tribes, I look at them as they're almost my board of directors. They tell me this is what we want. And so as the law has allowed these tribes to take their program, so now what we have done with where we are going with the electronic health record at the Indian Health Service is giving them that opportunity to come back into the system that we are building out, that we're very excited about, the steps that we have taken to replace our current electronic health record. We all know how critical data is and that we need to lean on that. Again, we learned that very, very clearly as a result of the pandemic, and how we need to continue to focus on moving forward and moving the system forward. So again, I'm just really excited about where IHS is at, and leaning into these opportunities that we have and that we've been working towards.
Thank you. So Susan, part of NIH, big enterprise, also lead the data strategy related work. And this is a little bit of an open question in terms of what's on the horizon. You've already used acronyms that are near and dear to our heart. You know, you heard about the USCDI Plus for cancer earlier. And so anything you could give us a sense in terms of data strategy on the horizon for NIH?
Absolutely. Well, in line with our ideas and interoperability is the idea to get data to researchers faster and quicker. And this data is participatory research data, genomics and other healthcare data. It's all controlled access data. So when a researcher wants to request access for using this data in research, it often comes to NIH for review. It can take anywhere from 10 to 14 days at a minimum for researchers to get access to that data. Recently, we've begun modernizing the way that we process data access requests and getting data to researchers faster, including a one-shot portal so that researchers can find and aggregate this data. Through that pilot modernization, researchers can now get access to many of our genomics data, at least in less than a day. And that to us is a major improvement in just getting the research data to researchers quicker. In line with the idea that we want to develop interoperability is the idea of harmonization of data, and this is the much harder challenge, quite frankly. We're pleased to be able to leverage ideas from USCDI+, particularly in the Cancer Moonshot, but not just in the Cancer Moonshot. There are avenues that we can pursue to use elements of USCDI+ to harmonize and create sort of common data elements across NIH that we can all agree to and all share in our clinical studies, and that will be a major improvement because it will put NIH researchers on a path that is able to integrate data better from the health IT industry settings, and that's really a goal, not just of myself, but I think also of our director, Dr. Monica Bertinelli. And finally, really putting the hands of control of data into patients, so patient participatory research is another element that this will certainly allow. So there are some really exciting integrations that we can use from the work that ONC is doing, but also just modernizing our own health IT infrastructure for research.
Yeah, and from a TEFCA perspective, you know, we heard earlier, I think Mickey called it the seventh exchange purpose. I don't know, we're going to start numbering them for everybody. But jostling for position number 7 is definitely the research, you know, case. Certainly there are networks out there today, but, you know, TEFCA provides a different type of scale and connectivity. And just to give a sense of, you know, like how that could change from a research perspective for NIH and the folks that you fund.
Absolutely. It will really create a much facile streamlined workflow between the health IT industry, our medical research infrastructure at academic settings, as well as within our own intramural clinical center to really get that data in the hands of researchers faster. As my colleague Rosalind pointed out, you know, COVID and the pandemic taught us a lot about data harmonization and data sharing through the National COVID Cohort Collaborative, for example. And I think that we can really leverage that to build upon it, to create much larger data harmonization across all of our different, at 27 at least, institutes and centers, each having their own platform or many platforms. That integration and harmonization would be a super big win for researchers.
Yeah, great. And I think, you know, as we heard earlier too, each of these federal agencies are, I would say, users or customers of TEFCA and the use of the network capability. Many others that are part of HHS as well. So Sharif is, you know, for VA, you exchange a lot of records today in the healthcare ecosystem. Your providers treating across, you know, both within VA and outside of VA. Could you give us a sense of, you know, your participation? Actually, see, you're representing here, you know, VA here today. VA's participation in TEFCA and, you know, the value that you think it'll bring to the veterans and providers.
I think it'll be tremendous value, and I've thought that ever since running an academic medical center in New Jersey and also being health commissioner in New Jersey. We've always thought that a national network of connectivity was needed because, you know, patients aren't tied to states, certainly veterans aren't tied to states. And so, of course, you know, being a system where we take care of 9 million, you know, patients and also operations in every state and U.S. territory, we absolutely need to be able to leverage a national network to be able to transition records back and forth. And so part of the interoperability pledge that we signed, which ONC is helping us with very, very meaningfully, is looking at ways that we can continue to build upon these use cases. I just talked about a suicide prevention use case where, you know, we really just get the information by the veteran level to these health systems so that they know about the Compact Act and the fact that we can cover that care. But also just making veterans more generally aware that they have a health system ready and willing to care for them at a very low cost and in many cases for free, depending on the disability rating. I'll also mention that, you know, as we continue to make these use cases a reality, we're looking at the potential for early stage companies come in with an AI tech sprint and assist our clinicians in mitigating the burnout challenge. They're going to be coming in this period of a tech sprint facilitated by GSA and other interagency collaboration. to actually test their products within our systems and workflows so that we come out with something that is scalable at the end. And so if it's scalable across our health system with over 170 medical centers, hundreds of clinics, these insights can then be worked with our private sector partners who are in every region of the country who will also benefit from TEFCA. And so the ability to scale and realize value for veterans depends upon us working with the broader healthcare system, and TEFCA will be absolutely an important vector for us to be able to do that.
Awesome. It is close to the end of the year, not that I need to remind everybody that, but also an awesome opportunity to ask for predictions or things on the horizon. We're each approaching kind of the last year of this term of the administration. Lots of things that we need to complete, milestones that we need to deliver on. Would be curious about anything that IHS is aiming for in 2024.
Wow. We need more money. We need more people. That's my list to Santa.
Yes.
But our IHS has just recently made a selection for General Dynamics to be our partner to build out the next electronic health record for the Indian Health Service. And as I said, we want to make sure that our customers are first and foremost, whether it's our patients or our tribes. They're both our customers, and we have taken great steps to integrate our tribal leaders and have them part of our whole planning process to make sure that we take their needs and their wants into consideration. And as we move forward, I think it's really important that we still continue to focus on what is the healthcare center our healthcare system going to look like, not just in Indian country, but across the nation. When we're talking about mental health, when we're talking about the high levels of fentanyl and suicides that we have across the country, there's got to be a better way that we take care of, that we have the data that's immediately available to us so we can then respond better and more appropriately to our people. Thank you.
Yeah, Susan, and you help lead Aim Ahead, among other perhaps high-tech initiatives through ODSS. Anything else on the horizon in 2024?
Absolutely. Thank you for the shout out about Aim Ahead. For those who don't know, Aim Ahead is a program that brings artificial intelligence capacity and capabilities across the United States, particularly for communities who are not participating in AI. So this would be underrepresented communities, rural communities, Native American communities. So thank you so much for mentioning that. And speaking of our collaboration with Native communities, I'm really pleased to let you know that on December 1st, we announced the funding of the first Native Tribal Data Repository. It's in partnership with Stanford and with the Native Biodata Collaboration Consortium, sorry about that, which sits on the tribal lands of the Sioux from the river, the Cheyenne River. So this Tribal Data Repository is part of our larger RADx COVID work and research. It will allow tribal communities to look and research and develop data sharing, data management, legal and ethical frameworks for tribal sovereignty and tribal governance of data. So for us, this is our first effort into a tribal data repository, and I'm looking forward to working with Dr. Karina Walters, who is the Tribal Health Research Office Director, as she moves forward in her plans for tribal sovereignty and tribal data governance. So that's something that I'm really looking forward to in 2024. And in a completely different thread, we're also looking at where in our research portfolios there are not common data elements for harmonization of data. And one of these is in food allergies. Food allergy descriptions are unstructured data in electronic healthcare records. And this is a real problem because 11% of American adults have food allergies and 8% of children have food allergies. We are not capturing that data either for research or very well potentially for healthcare. And so we are going to partner with the National Institutes of Allergy and Infectious Diseases to develop some common data elements, hopefully utilizing work with USCDI+, certainly for those behavioral elements, so that we can capture that data for research. And I hope that we can also encourage others to look into allergy and infectious disease, particularly in food allergies.
Awesome. Sharif, you had mentioned some of the suicide prevention, mental health related activities, other work that VA has planned in 2024?
Yeah, I think the most important thing that we can actually execute upon in the next 12 months is the capability for any clinician in any health system who's connected to TEFCA and connected to us through interoperability to know that they are in front of a veteran when they're in that encounter. That is exceptionally valuable information that, of course, we place a high premium on. But the more we educate our partners throughout the American healthcare system about the importance of knowing that you're in front of a veteran means to their health outcomes and to their care, the more we will see uptake of that use case. And so access to VA benefits is one thing, but also just really valuable clinical information on risk for mental health issues, conditions like PTSD, which is all too common, and of course, the risk for veteran suicide. The other reality we can achieve is finally getting away from the fact that the American healthcare industry is still the only sector that hands you a clipboard routinely when you come in. And so the day that I can cancel my eFax contract, which costs us millions of dollars a year to send records back and forth, is the day why we'll call you and Nikki and say, let's go party, because that means the care is much better coordinated for the veteran, which is why we are all here. And so those two realities will really be the foundation for so many more use cases that ONC and so many interagency partners will help us execute on.
Awesome, thank you. So we are right on time. You're seeing here, we have 3 feds. We have others that were on the panel before, many others across the HHS and the rest of the executive branch, not sitting on the sidelines, to the point this morning, and actively participating in the work that we do and collaboratively with us in a number of different initiatives. Please help them, just like you help us. We can't do it without you. Please join me in thanking them for giving their remarks, and we'll keep things on time. Thank you.
Plus you gotta hike up your shoes, your pants. Yeah, there we go. You got the pants. What for who?
All right, well, good afternoon, everyone. I'm Mary Ann Yeager. I'm CEO of the Sequoia Project, and I have the luxury of leading the TEFCA RCE team. And joining me today are representatives from the first designated QHINs. And I want to start by first thanking Mickey Tripathi and the ONC leadership team for their tremendous support for Sequoia and working with them over the last 4 years. It's been interesting, challenging, and also having an opportunity to work with such an incredible group of people makes it
fun. You might think that that makes us a bunch of nerds. Well, we are. So I also want to acknowledge the incredible team, the RCE team, if you all would stand so I can acknowledge our core team: Alan Swenson, Zoe Barber, Lindsay Elkind, Aaron Whaley, Dave Pike, Jonathan Coleman, as well as our as well as the folks in Chantal Warzola, Don Van Dyke, Hera Ashraf, and our friends at Spire Communications for all the marketing and stakeholder engagement, our standards and conformance testing subject matter experts, Dee Dee Davis, Matt Blackman, and Laura Bright, and finally, but certainly not the least, the team that actually worked with you all and your teams to get designated, and that's Sully Sullivan, Bill Mehegan, and Chris Dickerson. So I just would be remiss if I didn't. So I want to, you all may not realize that in addition to TEFCA being incredibly complicated, that we've also had to move at an unprecedented speed with the leadership of Mickey. So when TEFCA work started, it was measured in terms of years, and then quarters, and then months, weeks, hours, and now minutes. So literally, I think I got an update backstage on what the progress, and so that is just a signal of the forward momentum, and we will see that as we roll out TEFCA, as well as supporting the first nationwide adoption of Firebase Exchange in 2024. So. So the first question, I want to tee it up for Rob and then Stephen. You know, we've acknowledged that this is the start of TEFCA-based exchange. And so what are the key milestones you're looking for in 2024?
Thanks, Marianne. Hi, everyone. Good morning still. I know we're between you and lunch. My name's Rob Glotwijk. I work with Epic. And, you know, I think we all acknowledge in what we heard today, a complete and accurate medical record is essential to high-quality care. And when clinicians can easily exchange information, they can see the patient's full medical history and provide the best care. They can see the data from the MRI last week and avoid ordering another one, reducing the cost as well. And TEFCA is bringing clarity by aligning all of the regional initiatives into a federally endorsed framework. The Epic community is 100% interoperable, exchanges 16 million records every day, half of which with other vendor systems, but there's still gaps in universal interoperability. And collectively, we need to continue to work to close those gaps by engaging every provider in this country and helping them become a participant in TEFCA. For them, TEFCA will be the single on-ramp to nationwide interoperability. Within a couple hours of the Tuesday morning signing ceremony, there were almost 100 hospitals that use Epic and around 150 clinics live and exchanging data. My understanding is the minutes, I believe it's almost doubled already, and I expect very rapid adoption among the Epic community and others too. And really the milestone that I think is critical is reaching critical mass of providers on TEFCA as quickly as possible. That will be the key to all other milestones that we talked about this morning, all of the use cases. The providers are the key, and we need to reach them and help them become connected to TEFCA. So I look forward to the day when every provider in this country can answer the question, are you part of TEFCA, with a yes.
Well, Rob, I can't agree more. My name's Stephen Lane. I'm a practicing family physician and the Chief Medical Officer at Health Gorilla, one of the first QHINs, and I'm a user of the Epic EHR, and I fully appreciate that goal. I think getting all of the clinicians across the country live as quickly as possible is going to be critical, but there's so much more than that. There's so many more opportunities that we have to share the love, you know, to increase connectivity amongst additional participants in the TEFCA exchange framework, the payers, the public health organizations, as we've been hearing, as well as other clinicians that have not been enjoying the benefits of interoperability, the long-term post-acute care systems, the EMS, the social care providers in communities. So having a diversity of QHINs is really important for being able to meet the needs of all of these folks. And I think that's one of the milestones that I'm going to be looking forward to, is seeing the rest of the QHINs that are in the pipeline coming forward, because I think having that community community where each has their own ability to connect to different parts of the community of connectivity to provide services for specific groups that need to connect is going to be critical. I think we heard earlier about public health, and we're really looking forward to the public health implementation of TEFCA. I think in the coming year, we're going to see that. We heard about electronic case reporting. We heard about the ability to make queries for additional information, and that's going to be critical. We saw tremendous value from ECR during the early times of the pandemic, and seeing that spread is going to be wonderful, and leveraging the TEFCA connectivity for that purpose will be great. The other one, of course, we've seen already individual access service queries occurring on the framework just in the past 2 days. At Health Gorilla, we have 2 IAS provider organizations, Otis Health and Unblock Health, that were listed immediately, that are making queries, that are actually downloading data using the current technology, which is tremendous to see that individual access service moving forward. So I think we're just going to see a lot of advancement. Today, the past 48 hours, seeing thousands of transactions already occurring with data being delivered over this brand new framework is tremendous, and the coming year I can only imagine it's going to be very exciting.
Absolutely true. So Laura, now that TEFCA is operational and we have this incredible national infrastructure at our disposal, what do you think are the key benefits that people should be thinking about with TEFCA, and who should participate?
Well, thanks, Marianne. I think that all of you in this room are here for the same reason I am. You know, we want to improve care for patients. We want patients to be safe, and we want those patients to receive the very best care they can. If the clinician, the doctor, the nurse that is in front of that patient doesn't know about their medical care, doesn't know about their medications, doesn't know about their chronic disease conditions, and maybe that patient can't share, that patient isn't going to get the safest or the best care. And all of us know and have been working for a very long time to try to change the structure to allow those medical records to be available at the point of care. Not only, for our loved ones, but also for the people in our states and our country that we're responsible for. So that's the most important piece that I know all of you are here and all of you care about. The second thing I would share is that, in our company, I still am responsible for sales because I'm a teacher by training. And on a regular basis, I'm on the phone with doctors, with hospital administrators, with nurses, and we're talking about how to advance interoperability, how to reduce provider burden. Do you know what the first question they always ask me is? They'll say, who all are you connected to? And then we'll go into a long description about who we're connected to in their state and who we're connected to nationally. Now that we have this framework, I'm not going to have to really answer that question any longer because I'm going to be able to say we're all connected through TEFCA. And everyone is going to participate, whether you're a federally qualified health center, or a behavioral health organization, or a pharmacy, or you're a hospital. Everyone needs to share information in order for us to actually achieve the mission that we have, why all of you are here, which is to provide the best and safest care for patients and try to reduce that administrative burden. It made my heart hurt when I heard that we're still faxing. We've got to get past that. And these folks, the ones that I get to spend time with, are the ones that really are creating that infrastructure with us to make that change happen for everybody here in this room. So thanks, Marianne.
Oh, thanks, Laura. All right, why don't we go next with Jay and then John. So what are you most excited about with TEFCA, and why should someone participate?
I'll go first. So Jay Nakashima with eHealth Exchange. So I'm probably most excited because the government is kickstarting innovation, and we wouldn't have this velocity if we didn't have the US government involvement. I think after that, I'm most excited about public health exchange. So, we're already exchanging, facilitating exchange of adverse events for the FDA in 46 states using FHIR. And so I'm hoping we can use that as a launch pad for public health exchange within TEFCA. Above and beyond that, we facilitate electronic case reporting with our partners at APHL. And we would love to be able to expand that in 2024 to any organizations that are not yet reporting electronic case reporting. Another exciting thing is our work with payers. So we're doing some amazing work with some Blues plans related to prior auth via FHIR. And that would be super exciting to do in 2024. And with all of those use cases I mentioned, I think it's really critical that we involve the regional and state HIEs. Number one, they have unique data sources that we need to be able to tap into. And then number two, they have the relationships with the local public health authorities that we need to get connected. So it's important that we include them.
Great. So I'm John Blair with MedAllies, and happy to be here this morning, and thank you for having me on the panel. So what am I most excited about? It's funny, I had breakfast yesterday with somebody that went way back. I've been at this since 2001. And, and he was talking about, we hadn't seen each other in years, and he was talking about kind of my dream up in New York of what would happen with interoperability. And he said, what's going on right now is what you were talking about in 2004. And I said, yeah, and I thought we'd be there in a year or two. So I'm pretty excited that we're finally where I said we'd be in 2006. So, and what a massive amount of things that had to be done to get here. And Mickey talked about the Gartner hype cycle and the burnout after you wake up and realize it was hype, and then working on through. I'm gratified that we stuck with it. I'm very happy that the government stepped in again and kind of pushed this. I do think it'll be a catalyst to get us up to a place where again, I thought we would be long ago. And in fact, MedAllies, we run a direct secure messaging network, and we were kind of coasting along. And then when this was all mentioned about 2.5 years ago, and particularly with the leadership at ONC, Sequoia, Care Quality, I just said I cannot stop now. we finally have a shot. So MedAllies jumped in, and so what I'm excited about is really starting, getting to where I kind of dreamt about years ago. So, and when you think about some of this, we've had comments, and I don't want to repeat those, but I think the multiple new purposes of use, and Jay mentioned public health. I do think payment and operations is important. Individual access service, which we've been hammering at for 2 years. Finally, we just heard from Stephen that they're starting to see those transactions. So those things are there. I've said this before, though. We've been doing treatment for a long time, and people kind of think we've put that on the shelf, and that we've got these new purposes of use, and let's get into those. I hope we don't go too fast on that, but because we need to get it right as we roll it out. But we're not done with treatment, not by a long shot. And so I think that what this does by expanding the connectivity, we heard 70% of the hospitals, it's not even that good with ambulatory providers, other parts of the healthcare stakeholder community. As we push that out and knock off connectivity, we are now diving straight into data quality, data usage, And I think that's critical, particularly when you start looking at treatment. And then lastly, I see more collaboration than I've ever seen between vendors. And if you don't marry up those workflows on each end of those transactions, it still is clunky and it's still a problem. So when this gets to the place where a provider is using their system, they just accept, they're not even thinking about the whole interoperability piece, and those systems are working with each other, and the providers can do that, as if they're in an integrated delivery network. That's the kind of stuff I get excited about.
Absolutely. Speaking of things that are taking a little longer than some would like, we know that we will be supporting the implementation of FHIR-based exchange starting in 2024, and there's been just such an urgency to get that rolled out. So I wondered if each of you could share your respective plans for rolling out FHIR-based exchange under TEFCA.
Do I get to go first?
John can go first. He's so excited.
1 minute after you drop the IG.
Okay, sweet.
We're kind of chomping at the bit. We're ready to go, but we don't want to get out prematurely and have to make changes. So we're waiting for the Common Agreement 2 to be signed, and with it will come some technical final details that we'll polish off. And so if this happens in March, it'll be second quarter that we have it. And it's really important for many reasons. But again, back to treatment, it narrows and goes at another piece of that, let alone bringing in the payers, many other things. But we'll be there by mid-year if you get this in the first quarter.
It's not an if.
Okay, we'll have it mid-year.
I heard March 31st.
It's a when.
Okay.
So, we deliver, don't worry. Jay, what about you?
Yeah, I can think of 3 or 4 things, unfortunately. I'll try to be quick. But again, we're doing FHIR R4 already in 46 states, and so we're hoping we can leverage that. We're also trying to build authorizations using FHIR again, so that patients can get the coverage decisions they need much faster. Bulk FHIR is, I think, really going to be the holy grail for healthcare, because we have all of these organizations who have clinical and financial responsibility, and it's not practical for them to query, on a onesie-twosie basis for one patient at a time. And that's where bulk FHIR comes into play. Yes, there are performance issues with it. Yes, there are attribution challenges that we have to overcome. But I think we will see that in the near term.
As a HIE, you have to have a tool belt of every single kind of connection, because we are all, as HIEs, EMR agnostic. That means we need to be able to connect to every single EMR system that's out there. And every one of those EMR systems connects in a little bit different way. Mm-hmm. So our team can connect using every single standard that you can imagine. And the thing that's exciting about FHIR is that we are actually, truly, Nikki, starting to see a few EMR vendors that say to us, we want to connect to you via FHIR. We actually have the first 2 EMRs that we're working to connect completely for both queries and to be able to respond. They have FHIR repositories. And so, this is happening. For those of you who have been waiting for it to happen like I have for so long, we are seeing it happen. The EMR vendors are becoming FHIR ready and FHIR enabled, and when they talk to us, it is a viable connection option for them to connect into TEFCA via FHIR. To me, that's really astounding, because I like Mary Ann said, we've been talking about it for a long time. Now we're finally seeing it. It's something.
And I'll just build on that and saying one of the reasons I came to Health Gorilla a year or so ago is because they actually have a Fire native platform that, unlike a lot of the traditional providers who are using EMRs, like I've used Epic for years and years, there are a lot of smaller providers, novel care delivery systems that have built their own bespoke technology, and it is Fire-based. And so what we see already today is Fire in, Fire out of the Health Gorilla network. Now we have to use document exchange between the QHINs, but soon in the coming year that will be going away. So being able to do Fire between the QHINs and then Fire end to end is really the direction that we're going with the Fire roadmap, and that's going to be very exciting. But two of the early implementers that Health Gorilla brought live this week, VertaHealth, RX Live, they are both working with Fire and using that today. I think the other thing we heard is that in that HTI-1 rule, did you hear there was a rule that ONC dropped this week? There is the advancement of Fire-based standards for electronic case reporting. And I know the ECR team is here in the room with us today, and they've been working hard to be able to bring this forward and to be able to start to see that, with Fire end-to-end on the Trusted Exchange framework is going to be very exciting. So I think, in a sense, the version 1 of the TEFCA that we're bringing live this week is great. It builds on the success that we've had for 15 plus years building interoperability based on document exchange, but this really just sets us up to go to the next generation of exchange, which is going to be largely Fire-based.
Much already said about Fire. Very excited to see Fire come to TEFCA. 100% of our customers have Fire deployed. I think that the opportunity with the IG work that is looking to be published to follow that roadmap, the step 1 and 2, leveraging already well-adopted and deployed technology will allow us to scale that very quickly. And so I encourage, as that is finalized, that we look at what's out there, put it into TEFCA, allow apps to register simply. I hear that's a challenge right now, is finding all of the endpoints, registering with them all. TEFCA can solve all of that with very easy work. So I'm looking forward to that.
And having that shared, infrastructure we can work with. So I've been told we have a couple extra minutes, so I thought we'd do a lightning round, and maybe if you could just impart what you would like to leave with the audience, and is there a call to action you'd like to convey? I don't know who wants to go first with this. I'll leave it open.
I mean, I'll reiterate some of what I said at the beginning. Providers have enjoyed the benefits of interoperability for over 15 years now. Those of us on the stage here have driven that forward using the existing technology. But now there are so many other participants that can now begin to get more engaged, as this is a government-supported initiative. We've raised the bar for the security, the trust in the system to build on all the work that's been done before. So really expanding who can come under the tent and who can use the tools.
I think the call to action is to all of you is to participate.
Yeah.
I mean, we cannot make this successful as a nation if we have even one organization that has critical healthcare information about a patient that's not participating. And so that means everyone. And if you're not participating, this is the time to reach out to any of us up here, and we can help you participate. If your colleagues are not participating, if the organization that you need to share information with is not participating, this is the time to really take the call to action, to really, make sure that everyone that you work with is participating in TEFCA. And that's the only way we're going to be successful. It's the only way.
Yeah, I agree with Laura. I would say, participate with any of the QHINs or candidate QHINs once they're ready. And don't underestimate the power of the federal government to accelerate this innovation.
I'm going to stay on the participation track, but you've got to kind of break this down. The construct for QHIN is the QHINs, the participants that connected to the QHINs, and then the sub-participants behind that, and then the users. So participants or potential participants, if you've decided to do it, talk to us. If you haven't, figure out your QHIN strategy. Sub-participants, again, talk to those that would be connecting to us, and end users that want it, talk to those systems, the vendors or companies or platforms that have those systems that could, and say that, look into this so that they can have it.
Rob?
Yeah, participate, agree. You know, the dust is settling, clarity is here, no more being on the sidelines. We all need to join, be a participant of TEFCA, however you need to do that. Stephen mentioned, you know, providers have had interoperability for many years, and that's very true, but not necessarily at the national level. Maybe you're connected just to your hospital, and now figure out how to engage in your regions, that your region of roads and construction now has highway connections to everyone else in the interstate system that TEFCA is now bringing to the country for health information exchange. I know, that was big and red and flashy.
It's okay. They said we're fine.
On Tuesday, the secretary gave a little flack to Mickey for the three-letter acronym ONC, maybe standing for something different. But he ensured that there would be a Christmas, and so I would credit your organization as being a very giving organization. You give us proposed rules, you give us the opportunity to comment, you give us final rules. You're welcome. You give us a lot of important work, so I'm excited to get off the stage and get back to that work, and maybe next time you'll be known as the Office of Never-Ending Christmas.
It's the gift that keeps on giving. Well, thank you all. Congratulations again. I think at this point we're breaking for lunch and just ask everyone to come back at 1 o'clock. So thank you all.